Welcome. We're glad to have you here. I am Ayana McGee with the CMHEP TA Center, she, her pronouns, and I'm excited to be in this presentation with you today. We have Dr. Megan O'Reilly here with us from BEAM, our partner agency, and she'll be talking about microaggressions in healthcare, which is a very important topic. So just to kick us off with a quick disclaimer, this training is offered through the Community Mental Health Equity Project, TA Center, which is funded by the California Department of Healthcare Services, DHCS, and administered by the Center for Applied Research Solutions. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the California Department of Healthcare Services. The CMHEP TA Center receives AB 74 funding administered through the California Department of Healthcare Services, again, DHCS, to provide TA, technical assistance to counties and CBOs, community-based organizations, as well as support DHCS with updating the cultural competence plan guidance, which is in place to guide counties in planning their services and systems with the goal of reducing disparities at the local level. The Center for Applied Research Solutions, CARS, is the lead CMHEP agency to implement this technical assistance and training for the CMHEP. And TA is intended to provide culturally and linguistically responsive and data-driven behavioral health services to reduce disparities. TA is available at no cost to county behavioral health departments and CBOs and anyone else, any of our other stakeholders who attend. And as part of this initiative, I also want to call out that the Office of Health Equity through the California Department of Public Health also receives a component of this AB 74 funding to support community-based organizations through the California Reducing Disparities Project. Next slide. We are very lucky to work with a multidisciplinary team of partner agencies, particularly BEAM, Black Emotional and Mental Health Collective, which Dr. Megan is representing today. We work with this great partnership of agencies as they are our subject matter experts regarding things like cultural competence plans, health equity, training and technical assistance on cultural humility and such. And so we are always pleased to be able to highlight their work and their expertise. Next slide, please. The goals of this project are to design and help county stakeholders learn about behavioral health equity topics and trauma-informed services. As mentioned, this project provides training and resources to help counties build out their cultural competence plans and work in partnership with local community-based organizations and other local ethnic and community organizations. Next slide. Our approach to all work throughout this project is embedded in these values listed here on the slide. We intend to be equity-driven and anti-racist, strengths-based, trauma-informed. We value lived experience, community engagement, collaboration, and data for equity. These values inform, again, all the content that we provide through this TA Center and inform the experts that we work with to provide the TA and even the types of learning modalities that we offer. We aim to put these values into practice, even in these virtual events like the one today. So for example, as our trauma-informed approach, we started off with some music just as a way to get settled, allow folks to take a breath, grab a glass of water before we get started into the content. And we encourage folks to use inclusive language that is non-stigmatizing, LGBTQ affirming, and anti-racist. So for example, you'll note that we don't use terms like crazy when we're talking about important issues like mental health. We don't want to be stigmatizing. We aim to use first-person language, and we are also respectful of pronoun use. So we just ask that folks be mindful as well as we all participate in this space and step in and step back as we move through the presentation together. Next slide. So many of you might be folks from county departments, county behavioral health directors or ethnic services managers, MHSA coordinators. Some of you may be coming from community-based organizations, ethnic organizations, behavioral health providers. Wherever you're coming from, wherever you're at in California, we welcome you here and are excited to be in the presentation with you today. Slide. And then lastly, we just wanted to note the different types of learning opportunities that we'll be offering over the course of this year. We've been kicking off the project with these webinar opportunities as these short-term, quick-style learning opportunities. But as we move forward over the next few months, keep on the lookout, stay on our listserv. You'll see some longer-term learning opportunities like learning collaboratives and leadership academies. And more information will come your way as that comes forth. So next slide. I think we are now ready to hand the mic over to our phenomenal presenter, Dr. Megan O'Reilly.
Happy to see everyone here. A little bit about myself. I use she, her pronouns. My name is Dr. Megan O'Reilly. I am here on behalf of BEAM, Black Emotional and Mental Health Collective. Here are just a few bullet points of how I move and navigate the world. I'm a licensed psychologist. I have my own organization called Inherent Value Psychology, Inc., because I believe in the inherent value of all people. And I uplift and center Black and marginalized communities. Did a 6-year stint at Stanford, and now I'm out on my own. I still lecture there. And so I'll be bringing to you some stories and anecdotes and case studies of just my walk and how what I've experienced on both sides of the microaggressions conversation. So welcome, everyone. Some slides I will be moving quickly through, and some slides we'll be taking some time on because we have a precious 50 minutes and so much richness to cover. But I do want to pause here. Why? Because this is the BEAM's mission. You can check it out more on their website, but I just want to read this and start getting us envisioning and in alignment with why we've gathered today. So BEAM is a national training, movement building, and grant funding institution that is dedicated to the healing and wellness and liberation of Black and marginalized people, right? So healing, wellness, and liberation. Microaggressions actually fit into that. We're going to learn today about how microaggressions is actually a sign or a symptom of disparities in healthcare. So this is my organization side. My tagline is reclaiming our worth and wellness. And so when we commit less microaggressions, we actually are providing better care for our clients. Okay, let us dive in. Just a few intentions today because we might be all over the spectrum in terms of our understanding of microaggressions and our psychological safety around it and how we feel about it. So much like I start my day with intentions, I also start my webinar with intentions. I hope that you listen with your full self. What do I mean by full self? Not just your intellect, but your emotions. I like to decolonize mental health and say there's a lot of ways that you know things, not just what you've learned and studied. So let's take it below the chin today. I want you to know with your heart, with your gut, with your intuition, what feels right. I do want you to be challenged, right? Like, ooh, can I tweak this? Can I push myself into a growth edge on this or learn further after today? And I also hope that you're inspired and that you take something from today that will translate into better care for your clients and whoever you serve and your relationships. Okay. We do have a few learning goals. You know these. That's why you registered. And so I also want to share my positionality. Some of us might be familiar with that word. It basically means my constellation of social identities, which is very crucial for me to know because we often microaggress from our privileged identities, not so much our marginalized identities. So for the time being, I still claim young. I am a cisgender woman. I'm first generation Caribbean American, educated. English is my first language. I had enough growing up, and that's a little capture for class, social economic status. Sometimes I ask my clients, did you have less than enough, or more than enough? Just to kind of get a gauge for those ACEs, those adverse childhood impacts, which can be very correlated to class. And I'm vaguely Christian now, a raised Christian, now identify as more of a Unitarian Universalist Buddhist for anyone in the room that knows those faith walks. And I exist in a petite body, and I'm temporarily abled. So privileged to have an abled, healthy body for the tenure of my life so far, okay? So if this was a longer workshop, I actually have a worksheet where we get to actually map out given the big 8 social identities, where am I privileged? Where am I targeted? Because when we have a marginalized identity, we're more familiar with that, but we can't leave out our privileged ones as well, because that's where some of our blind spots might exist even more. Okay. Let's dive into the term microaggressions. I wish I could get a quick show of hands on who doesn't like that word. Sometimes these microaggressions are macro or don't feel very micro. However, that's the term we have. Psychology likes to name things how they name things. But I do want us to know, because this is Black History Month and because it's history and it's accurate, that even though we might think of Daryl Wing Sue for microaggressions, he's really expand the topic and applied it to other identities, not just race. But the term was coined by Harvard psychologist Chester M. Pierce, right? Sometimes our psychologists of color, our psychiatrists of color kind of get lost through time and history, right? So he did coin this term. He actually called it death by a thousand cuts. Maybe that term wasn't as malleable or swallowable as microaggressions, but he did start recognizing and communicating, especially with his African American clients, just the accumulation of small slights and incidents and not knowing how to manage them. And he called it this conspiracy of silence, right? So we're going to talk about what's the impacts of microaggressions on the microaggressee. And one of them is not knowing how to respond. Did that really just happen? Another thing we want to hold is that we can microaggress on all the isms, right? It's fair game. We can microaggress around race, class, sexism, religion, homophobia, transphobia, xenophobia, sizeism, language, even nationality. So there's a lot of areas to be mindful of. And oftentimes people can get a little fatigued around microaggressions, like, oh, how am I going to know all these things? How am I going to be aware? And it is about staying conscious, and it is about cultural humility. We're all going to step into it, right? I like to sometimes introduce that even though I've been microaggressed around race and gender, I have been the microaggressor around sexuality, religion, and even nationality, right? And so just a humbling moment that we're going to receive, but also be the deliverer of microaggressions. And once we can hold and accept that about ourselves and about this phenomena of microaggressions, we're more willing to learn and move forward. Okay. So here are what we call in social justice spaces the big 8, the social identities that we need to be mindful of, right? There's a little box down here that adds a few more that are emerging in the conversation, like political affiliation. Sometimes we feel very unabashed at degrading or making strong comments about someone with a political affiliation different than ours, less like we would race or gender, but that's on there. Physical attributes like size, language. These are the areas we're going to be considering. Okay. And I want to talk about what is the message that is being sent? Why is a microaggression harmful, right? Well, if you ask someone who doesn't look European where they're really from, even though they're a citizen, you could be making them feel like an alien in their own land, right? If you say, oh, you're so articulate, which many of us probably have gotten in this room, and you're like, is that a compliment or is that a backhanded compliment? That is a statement around the ascription of their intelligence. Where were you putting the bar and why are you so impressed about someone's articulation, right? So here are just some of the messages behind the microaggression. Take a moment and look at some of these. Pathologizing cultural values or communication styles. This is a large reason why people of color, namely Black folks, want a Black clinician, right? I can't tell you how many times a Black mother has told me in session about being spanked or giving spankings and not having to worry that CPS is going to get called, right? Because maybe that is something more familiar in our culture, right? Or other small nuances of who's in the home, grandparents living there, or multiple cousins, right, in the family constellation. Just understanding that different cultural dynamics aren't going to be pathologized, right? This is part of the reason why people want a match between their identities and the identities of their therapist and counselor. Okay. So as questions are coming up, we're going to be gathering them for our Q&A. Okay. Let's get a working definition. We got a lot of preamble, right? So a microaggression is actually a verbal or behavioral or environmental slight, intentional or unintentional, that communicates either a hostile, derogatory, or just some negative attitude towards a stigmatized or marginalized group, right? So verbal, we know verbal. We say something that lands on the person derogatorily. Not behavioral. I'll tell the story of my colleague who's a Black male. He talks about how he was in the elevator and a white woman joined him in there, and she crunched herself up in the corner of the elevator as to not be close to him. That made him feel all types of ways, as you can imagine, right? Or you're walking down the street, people cross to the other side because they don't want to be in proximity to you. Those are behavioral. Not giving eye contact can be behavioral. But what does environmental mean, right? We're often not thinking about this one. Well, I remember going to the dentist once and just sitting in the waiting room, and on the table was a Jet magazine. Who remembers Jet? Anybody? Drop a yes in the chat if you remember Jet magazine. And I really enjoyed that because that told me that someone was expecting a Black woman to be there or a Black person to be at this office and to partake in this magazine, right? Essence, Jet, anything, right? And so that can be an environmental cue. There's a lot of research that says no environment is neutral, right? Who came up with beige walls, right? Beige is still signaling something. So what artwork, what color, what reading periodicals, what do you have in your space that signals inclusion, right? In my office at Stanford, I had flags, I had Black Lives Matter signs, I had a lot of things that people could read into the cue that this would be a safe space, okay? So that's our definition of microaggressions. They actually break down into three other exclusionary behavioral types: micro assaults, micro invalidations, and micro insults, right? So insults are just insensitive comments that display disrespect. Micro invalidations are experiences when a person from the underrepresented group is discredited or minimized. And then micro assaults are at the top, maybe the more egregious of the three. And these are slights or insults that they're intended to be hurtful, right? So that unintentional piece drops off by this point. This is name calling, potentially slurs, avoidant behavior, purposeful discriminatory actions, okay? All right, why are we talking about this? Why does it matter? Well, there's some impacts on the microaggressee, right? I think we also should study what happens to the microaggressor, sometimes guilt, sometimes shame, that kind of stunts us from growing. But for the microaggressee, in the short term, there is what is called attributional ambiguity, okay? Say that 3 times fast. This basically means you're wondering, those of us of CBTers in the room, we know what attributions are. We're wondering what meaning can we make of this? And the ambiguity is we don't know. This can lead to rumination. This can lead to sleepless nights. Did that just happen? And did it mean what I think it means, right? And then you have a decisional fatigue. Since you don't know if it was intended to be harmful, what do I do about it? Do I speak up and become the race baiter or the sensitive woman or the aggressive person? What do I do? Do I speak up now? Do I speak up later? Is it too late? We actually have created a flow chart that can help people walk through how to respond. Safety is always first, physical and psychological. Catch-22 of responding, what are the consequences going to be? Remember, microaggressions tend to happen to people in marginalized identities, usually with less power in the dynamic. So should I even say anything? What will happen to me? Especially for my students and grad students where their funding is connected to their PI's opinion of them. Oftentimes they don't respond. And what does that do to the sense of self, right? And what does that do to the relationship? And then a lot of untold cognitive and emotional energies are spent. Can lead to anxiety and performance, or even depression and withdrawal. I don't feel like I belong here. I'm going to start moving back, right? Of course, all those death by a thousand cuts over time can leave a person feeling hypervigilant. So there's more cortisol, which we know erodes the body over time. One of the first things that I love teaching people is how to downregulate their nervous system through breath work, through grounding, through imagery. So we're not constantly on edge, right? Feeling ostracized, othered, and it can lead to depression. So microaggressions isn't just a fad or a trend or a buzzword, even though it's talked about a lot. It's actually harming us physiologically and psychologically. That's why we've gathered here to learn what to do about it. Okay. Quick story before we dive into some engagement. So I shared with you that microaggressions send all these different messages, right, underneath the statement. Quick story from my own life, and I want to see if we can spot the microaggression. Okay. Flashback to what is it, my fourth year in grad school. I'm floundering with my dissertation, feeling very stressed. And I go into my college counseling center and I get paired up with a counselor, and he's doing an intake, which is, asking me a lot of questions for the therapist, not for the non-therapist in the room. And he's asking about my family constellation, right? I just want to talk about the dissertation stress and wondering if he can write me a letter that will give me an extension. That's what I came for. But he's asking me about, my background and my family and history. And I'm answering, blah, blah, blah. And he says, who's in the home? Who do you live with? I said, well, both my mom and dad are nurses in the Air Force. I have an older sister, blah, blah, blah. And he's like, oh, both parents are in the home. Excellent. And he jots that down and goes on to ask me other questions. Real quick, he kept it moving. Well, what was the microaggression there? I'm going to look at the chat. Aha, Dr. Anna is on it. Cynthia, Sinetta, Jesse, yes. Jesse, assuming that I was in a single parent household. Yeah. Jill, everybody's on it. Brenda, both parents. Now, just imagine for a moment what that did do to our therapeutic relationship, right? He just revealed to me that he's making assumptions about my race and my family and my culture. So it sent this message of pathologizing values or cultural styles. But here's the thing, after finishing my training, I actually had kind of retrograde empathy for him. A lot of us get what I call the 31 flavors of diversity, kind of a Baskin Robbins training around diversity. And he was probably told in the week about African Americans that we may come from a matriarchal family and culture due to systemic oppression, which is not wrong. There may be systemic forces why fathers might not be in the home. So when you're working with a Black client, ask about the family constellation and see if the father, who's in the home, and be ready to hear that there's a multi-generational home. You probably got trained in that, right? And again, not incorrect. However, the surprise, the kudos, almost a communication of, oh, but good for you, you have both parents, didn't land well on me, nor would it on most people, right? So there is this deeper level of consciousness we need around what we've been trained on, what might be largely true for communities, and what the nuance is for each individual, right? So I like to say we want to be recognized for our differences, but not reduced to them, right? And so I'm glad he had a lens, but the lens didn't land quite right in that particular situation, okay? So let me drop in the chat. What I have for us is some engagement. I want to pause here for a moment and ask you, when was the last time you committed a microaggression, since we're just holding that everyone has? And what was that microaggression around, right? Like, for example, what identity did it come from? Let me present the screen. Did it come from a privileged identity that you have, thinking about your constellation? Did it come from a marginalized identity? Or was it an intersectional identity that you have? That's for game two. Mhm. Let's see some responses roll in. All right, intersectional is in the lead. Interesting. Mhm. Let's get the, oh, there's quite a few of us in the room, 98 of us. So let's get maybe at least 20 responses just to see. All right, neck and neck. Okay. Okay, I'm going to let this play on, but I'm seeing that really, which is supported by the literature, we often aren't microaggressing from our marginalized identities. We can begin to answer as to why, right? We know a lot more about that identity by via experience. We're more aware. We've been taught to be aware due to survival. It's those privileged identities, or even the intersectional, where we might step into it a little bit more because we might have foggy spots. And even saying foggy spots is something I've learned rather than blind spots. Someone from the ability community told me not to say blind spots. So we might have foggy spots or places outside of our awareness. Okay. All right. Privilege is in the lead. Now let's take a moment for open answer, right? Take a few moments, same link. How did my microaggression likely make that other person feel, right? Did it make them feel ostracized? Did it make them feel less than? This is a nice empathy exercise because when we microaggress, we're usually thinking about undoing the harm or that wasn't our intention. That I didn't mean to have that impact. We're trying to protect ourselves, but and in so doing, we're not empathizing with the other person. So not knowing what your microaggression is anonymously here, you're getting a lot of good shares. It made them feel distant, not seen, defensive, most likely less than, small, makes the other person question themselves. Thank you for that share. Yeah. Othered, even shameful, minimized, forgotten about. Yes. These are all feelings that over time really change the environment and the relationship. Invisible. Now let's think about if this was happening with your physician or your clinician, right? Not just friends or peers or even romantic partners, but someone you're asking for help with for your physical or mental well-being. That really shifts the dynamic. Offended. Yeah. Okay. Thank you. Let's shift back to our slides. Okay. So looking at microaggressions in healthcare, yes, I'm still sharing. There's an inherent power dynamic, whether we are acknowledging it or not. As the clinician, physician, whatever role you're in, you have more power. Someone's coming to you for help because of your expertise. You're likely to have foggy spots, not blind spots, because you're an expert, right? Once you get labeled with either letters or a degree or a title, you take on this role of knowing it, right? Or should be very adept in something. And that can make us, depending on our ego size, that can make us more adverse to feedback, right? So you're less likely to receive correction, right? Now, in healthcare, this can create a rupture, it can create a disconnection, but it can also create a lack of sharing, right? Your client might not share all their symptoms or what it's really like for them, especially if it was a minimizing microaggression, right? So the big piece here is that there's a deep correlation between microaggressions that happen in healthcare and unconscious bias that lead to health disparities, okay? So there is a bridge between the poor care that people of color and minoritized people receive and our worldview, right? Our microaggressions, our biases. Microaggressions are essentially emblematic symptoms of our bias. What we're thinking is true, what we're expecting, what we're assuming, and then how we show up in our roles as providers. Okay. That's why we're here. Let's look at a couple, right? It's always good to get concrete. So this is a bi-directional arrow, right? You can microaggress your client or patient, and they can also microaggress against you. So let's say clinician to patient, right? Saying something like, I might lose you while I explain this, but, Ooh, I see Kenneth shaking his head, right? That's a blow to their intelligence. Now, it could really be a complex situation, right? But we could say instead, stop me if any part of this is unclear. Sometimes I like to assume that they do know. And I say, you're probably already familiar with this, but let's just go over it in detail to make sure we're on the same page. And then they're like, yes, I am familiar, but go ahead, gonna lead with the empowerment. A clinician could also say, do you have a history of asking for this medication? Especially if it's a narcotic, right? That can make someone feel like a drug seeker, even though they really might need that drug and might not even have a history. But some questions can land more interrogaty or proby than necessary. And the worst one is the pain really that bad? Right? This is a minimizer. This is one African American women get quite a bit of, right? From that historic, systemic, very deeply racist belief that Black folks can manage and endure more pain, right? So is it really that bad? Do you really need all these tests? One of the evidence-based methodologies that people coach minority folks in is if your physician is going to deny you a test or a scan or a blood test or a biopsy, to ask them, can you document in my chart that you are denying me? I requested this and that you're denying it. It might make the physician a little huffy, but they might think twice, right? Because of that inherent power dynamic, we really got to teach people how to have agency and autonomy in those meetings, right? Patient to clinician. Are you the nurse to a female physician when she's the doctor, right? Or I need to see the doctor to a BIPOC, a Black, Indigenous, person of color physician, assuming that because of their apparent ethnicity that they're not the doctor. And one that I've gotten before, how old are you? To someone who seems a little young, right? Blessing and a curse, but really, these are all about credentialing. What are my biases around who is equipped to do this work, both age, ethnicity, and gender, right? So any demeaning, disrespectful, generalization type comments are the things that we're thinking about in terms of healthcare. Okay? You probably have examples from your own life, things you've heard, things you've done, and things you've received. Okay? Just a quick graphic for the visual folks in the room. Your client is always embedded in their own family culture and dynamic, which is embedded in the societal norms and assumptions and pressures, which also is against the backdrop of systemic oppression. And so are you, right? I like to say we're all pickled in certain isms, right? White supremacy, capitalism, patriarchy. We're all pickled in these things already, in the brine for too long. So it becomes our job to actively look for and try to counteract, right? It's not if, it's how much and when is it showing up. Okay. So let's talk about managing. We're doing good on time. Let's talk about managing, how to respond. I have some sound bites for us that might work well for you, and then we'll get into some questions. So if we're thinking about how to systemically attack microaggressions in healthcare, we need to do it on all the levels. Let's actually start on intrapersonally. That's where we have the most autonomy to do the work. Intrapersonally is within yourself, right? So you're coming to these webinars, you're getting this education, you're starting the conversation with yourself, right? So commitment to just social justice issues globally, right? Holistically. And prompting yourself to move beyond your ego. Yes, you know a lot of things, but you can't know everything, especially when it comes to people, right? So continued learning and cultural humility, right? That's a whole other workshop on really what that means. So a commitment. Interpersonally, we do need some psychological safety, right? Being able to have a model within your community, within your staff, where learning and being corrected is rewarded, is a norm, is welcomed, is embraced, right? From leadership on down. How do we hold when we've made a mistake? How do we not shame or blame and actually take it as a growth experience, right? How do we actually bring up when we've made a mistake? Our process, this could have been something. The microaggressee didn't say anything because there obviously might not, but I think it was. How do I go back and repair, right? I actually have a friend, they are white. And when they meet with a client, regardless of their ethnicity, but particularly a person of color, they say, as you can see, I am a white therapist, and it's likely that across our therapeutic relationship, I'm going to say something that isn't going to sit well with you. I might even make a microaggression that's outside of my awareness. If and when that happens, I would like for us to do bop, 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 right? And I think that's really important in consent setting and power sharing and setting the stage. She's owning up front that she's aware of this dynamic and contracting with the client about how to repair if and when, assuming so, that rupture will happen, right? Because most clients of color will just let it go and then maybe stop coming if it was sizable enough. So take a moment to yourself. Could I say something like that? How do I feel about that potentially coming off the pedestal of power, right? I actually think it's quite powerful in a different way. And then systems level, training on disparities, understanding what equity and acceptance of microaggressions is, accountability. I like to say compassionate accountability, and a robust feedback system. How can we always be looking at this, not just, Black History Month or different times during the year? How do we infuse this awareness into everything that we do? Here's what it can sound like. So there are some evidence-based ways to think about being an upstander. So you're witness to microaggression happen, or how to respond when you committed one and you want to go back and fix it. One way is to inquire, right? This might fit some folks. Find what resonates with you. The inquiry is, I'm curious. What makes you ask that? Yeah. What makes you believe that? Right. So this could be the microaggressee saying, what makes you think that the pain isn't that bad? I'm telling you that it is. You're like, why? Turn it into a question. That puts the work back on the other person. You could also paraphrase or reflect. So it sounds like you think that because this person is a physician of color, that they're the nurse. And when you put it very clearly, they're like, oh, that's not what I'm saying, even though that's what they're saying, right? So you can paraphrase, you can reflect. You can also reframe. I love a good reframe. I'm wondering what that message is sending to her. So let's say you witnessed one, and you can ask the microaggressor, what do you actually think that sent in message? Do you think you would have said that if this person was opposite identity, was male, was white, was older, was obviously of a different class, was cisgendered? Would you have said the same thing? Express the impact of the statement on you, right? This usually takes some courage, maybe a prior relationship, some fortitude. But I felt blank when you said blank, and it does this to me, right? And so if you have the relationship and safety, that's an option. And strategic questioning. How might we examine our implicit bias to ensure that gender, for example, is not playing a part in this process? Those of us who are leaders in the room, this prompt can be a great one in a meeting or in a system, or when you're deciding something, right? Or admitting people or hiring people. Always asking, okay, we got a process going. Where's the social justice component? How are we looking out for bias? Anyone can say this, but if you're in a leadership position, it behooves you to take this on. What do we need to be aware of? What approach could be different next time if there's something we can't change this time that might have a bias baked in, right? That's that systems level. And then revisit. Let's say a microaggression happened weeks, even months ago, right? Sometimes years. I want to go back to something that was brought up in our conversation, at lunch, in our meeting. Let's go back and revisit that. It's still lingering with me. Sometimes I coach people to use the emotional capital, if you have it in a relationship, and say something like, if you were feeling the way I was, I would want you to come to me. So I'm going to come to you with this. That usually perks up people's ears and takes them out of their head and into their heart. Right? It's like, oh, something's lingering with you. You're feeling the type of way. Let me hear about it. And when you're actually hearing, it will land softer. Okay. Well, those are some examples. Let's go back to our Mentimeter. Thinking about inquire, paraphrase, reframe, e- expressing the impact, using strategic questions, and revisiting. What might you feel most comfortable? Which one of these strategies might feel best for you? Let's take a look. Which upstander intervention do I feel most comfortable to try? This is just a little ranking, just to get a quick gauge of the room. See if some roll in. I see some coming in the chat too. Paraphrase, express impact. See, Cecilia's going to reframe perhaps. Yeah, it really depends on the context and whom you're with. Mhm. Okay. Mhm. Let's see what's coming in the lead in terms of ranking. Inquire. Asking that question. Mhm. Excellent, y'all. Thank you. Let's head back to our slides. So to bring it home here, I want to open it up for some Q&A now. Yes, we have about 10 minutes. I like to say, listen to your body for a moment. Your body's always speaking to you, whether or not you're listening. See what's resonating. That means that really vibes with me. I get that. I like that. It's true to my experience. But also look for what you might be resisting, right? Like, no, that can't be so. Or is that really how it works? Both of those responses are data to you. So take a moment, listen to your body, see if there's a scenario you want to process or something on your mind. And I will ask Jeremy and Ayana to let me know if there's questions already in the chat or in
Hi,
the.
Dr. Megan, it's Jeremy. We did not gather any questions. There were a couple of areas that were mentioned that I just wanted to elevate, particularly around things that have been said to providers, but not understanding how those things could be microaggressive.
Mm,
So just to sort of put that into the fold as a discussion.
mhm. Excellent. While folks are maybe generating some questions, let's go back to that point. So things that your patient or client might say to you that might be microaggressive. Okay. Well, in our slides, we looked at one that was said, are you the doctor? Right? Could seem innocuous, right? But we could also think about that upstander intervention. Like, would you have said that if it was an older white male in a lab coat? Probably not. So, what is prompting? We could think, what is prompting that client or patient to say, this isn't the doctor? I want someone older, maybe someone who's male, maybe someone of a European looking ethnicity, because that's what my image of doctor is. That can be microaggressive just based on that definition that it is a probably unintended statement that communicates a negative association or something derogatory or an assumption that you don't belong in this class, right? You're not what I expected. And thus I probably don't feel as safe or have questions about your competency. I just don't think you're my doctor, right? So it can be anything that makes the physician or clinician feel kind of dismissed, minimized, or unseen in their role as the doctor. Mhm. April's saying, as a woman of color that has experienced microaggressions throughout my life, my cultural pain has resulted in me becoming microaggressor to other groups. Not proud of it. Thank you, Rachel, right? Sometimes we can get co-combative, right? Internalizing so much can actually get in. I say it's kind of the smog we breathe in, and then we cough on other people, right? And so not being proud of it is the first step, right? How can I lead with some more compassion, understanding for myself, but also others, and start modeling? I won't change it overnight, but you want to be able to be proud of how you're moving, right? Mhm. Yeah.
Dr. Megan, it's Jeremy. There's another question that came through. It's saying, how would you address a person who is ignorant to their micro/macroaggressions, or who become insulted if you bring it up, or feel attacked, or feel that you are accusing them of being racist or prejudiced?
Well, this is a great question, because this is kind of the number one fear of anyone microaggressed who wants to say something about it. So the question is, how do I address it when that is going to likely be the outcome, right? Okay, there's a couple different approaches. I'll give us three to choose from, because options, I feel, is power. It's empowering. So if you know, pretty sure, because you've seen it demonstrated before to others, that the response is going to be quite hostile, you don't have to go directly to them. One option is to think about anonymous feedback. Does your organization have a portal or some way to report things? Now, this is hard because given the microaggression, people might be able to identify that's you, right? But can you give some type of anonymous feedback? Especially if there's cyclic review cycles, like if it's a professor or a physician, is there some way to give it anonymously, right? So you can still have your voice. Secondly, another option is there a channel you can take? An ally, a friend, someone who is not in the same position that you are, because you're worried about some retaliation, that can speak to it on your behalf, right? And you can inform them how much or how little detail you want, because there's someone who can bring this to the person's attention, especially if it's going to be something that's damaging your path, your education, your healthcare in a way that needs correction. Can we get this to this person, this defensive person, in another way, through another person? That can be hard. And then lastly, the last route is if you do bring it up to the person directly yourself, it usually requires some mediation. Who can you bring with you? I often give this to students quite a bit, because after that meeting, just between the professor and the student, it's he said, she said, or they said, and the professor has more power, or the physician has more power, right? And so usually what they said is what stands, right? So can you bring in a witness? Can you bring in a third party? Sometimes it is a counselor. Sometimes it's a person from another department or in that same department, to witness the conversation. Sometimes having another set of eyes on it makes the defensive person act more right, right? Not just be crazy on you, because of the inherent power differential between that dynamic, right? So there are options, but I always like to think, what is the goal? What is your goal, right? There can be a lot of different goals. Is it on principle? This wasn't right. That's a valid goal. Is it, I need to rectify this so I can move forward in my healthcare or my education? That's a great goal. Is it, this is I need to stand up for myself and have a voice here? That's a great goal. Whatever it is, thinking about the goal first, what you need to replenish or be restored, will actually help you think of the methodology. And it doesn't have to be right away. Oftentimes your physical and emotional health and safety need to be secured first.
Hi, this is Ken. My biggest thing is, even though I'm white, my biggest microaggression is when other people find out that I have bipolar disorder, judge me on that alone. Even when I go see my MD and he finds out I have bipolar disorder, they dismiss me or knowing less.
Yeah. Mm-hmm. Mm-hmm. So you're the microaggressed in that situation. Oh, yes. You can have the royal flush of privilege, right? And still be microaggressed against. So you could be a white, wealthy, cisgendered male who speaks English from America, able-bodied, heterosexual, and have a mental health condition or something like that. So what is your question, Kenneth? People don't see that as a microaggression? It is.
It is a microaggression, and I'm just trying to figure out how best to handle that as far as dealing with, I don't say medical personnel, but with, I won't say regular people, but with other people that kind of microaggress me, and try to educate them better on how to handle me.
Yes. That's a lot of work and what we call emotional labor, right? And I would say dole out that emotional labor for those people you want to have most connection with. Because some people might be convinced about what bipolar disorder is and might not be willing to meet you all the way. And so sometimes I let people know to return microaggressions to sender, return it to sender. It's less about you and more about their worldview, right? And so disrobing as much as we can, because it does impact, disrobing ourselves from that, it can be helpful.
I just want to thank you, Dr. Megan. This was a phenomenal presentation. I appreciate how much concrete examples and strategies you included. There are things that I'm taking to use for myself as a person who receives care, as a person who works with colleagues and in the workspace. I'm taking several things away from this presentation. So thank you for that.
Thank you.
And thank you everyone who's attended today for rocking the chat. There were so many great reflections and thoughts, and I've learned a lot from you all as well. With that, we'll go ahead and close out. I hope you all have a lovely day. Thank you again, Dr. Megan, and everyone for attending.